Hey everybody, welcome back. Ed Bowder and Dan Swechter on the Overrun's YouTube channel. We're joined today with Eric Jaeger from True
Yes,
North Group. How are you today?
very good.
Good. We're here to talk about ketamine, a drug that we love. We've talked about on the show many, many times. One of my
We go both
EMS
ways
drugs
with
of
it, Ed.
choice. We
We
have, yeah.
love it, but we sort of,
We
we
love
got
ketamine like
so
we love
really
that cousin
good,
we see it.
we love it now.
Yeah, we love ketamine like that cousin we see at holiday parties. Like we love you, but we don't have to see you every day. So Eric, we've talked on the show before. Certainly with the Elijah McClain case, this became a lot more prevalent. The use of ketamine and how effective it is as a treatment. Um, Give us some of your background opinions on this, and then we'll get into the use and how we can use it more safely as an industry.
Yeah, certainly I, like so many in our profession, focused on the Elijah McClain case when it burst on the national scene. It was closely linked in my mind with the George Floyd case as well, although there were no EMS medications there, and EMS really came in only after the fact. And it really caused me to begin to take a hard look at other situations where there have been deaths in custody, either involving law enforcement alone or involving EMS. And my focus and goal is a little different than some other people. I for sure want to make sure that, because one of the things I primarily do as an EMS educator is train other paramedics and EMS providers how to manage these situations. My goal for sure is to keep patients safe, because that's one of the primary things we do. But also I have a pretty heavy focus on keeping providers, EMS providers, and our law enforcement colleagues safe as well. That is typically safe from the risks associated with when these bad events occur. Uh, so yeah.
And I think that's right. I think when the Elijah McClain case broke, there was a lot of talk of like, well, 500 milligrams of ketamine is the proper dose. But I wonder that, or I guess I worry that we don't take enough time to talk about how the drug works. And, it's a drug just like any other drug. So, Danny, when you think of giving ketamine, talk about some of your concerns when you're out in the field, because I know you and I kind of share some of the same
Well,
concerns.
why don't what I could start with is, why don't I talk about the failures when I gave this medication? When I was first in service down there, we brought it on the trucks. We got told it was a miracle drug. It did everything. It was the floor wax and a dessert topping, right? Like the old saying, sketch. Um, it would do everything. It would never drop the blood pressure. It would never cause apnea. People would maintain their airway reflexes. And we started giving it, and then we'd start finding strange things like, oh, their pressure did drop. Well, that's weird. Or we'd have apnea because invariably we pushed it too fast. And that does happen with this medication. So we were kind of on the Dunning-Kruger curve. We were kind of like the I know everything stage, and then we kind of got into, oh boy, this is a problem. And I think now I'm climbing out of my the trough of, where I'm like, oh my God, I know nothing about this drug. And I educated myself, and I'm like, it's really good for what we use it for, but you have to really be aware of what we're doing with it and what can happen with it. It's very dose dependent. It's very time dependent. And Eric, you can help me out, jump in any time. But these are things that we weren't taught initially in service, and I think these are important things to regard. Yeah, I think those are all extremely true. I think the other thing to understand is that when we use ketamine, if I had a room of 50 healthy people and gave them all ketamine, and said something kind to them as they went off to sleep, they'd all wake up. There'd be nobody who became apneic as long as I was careful in how I administered it. And they'd all wake up and tell me they'd had fabulous dreams, restorative sleep, and feel great. I think using it in healthy individuals is very different than some of the circumstances where we're called upon to use ketamine. So if we're looking at an agitated patient that the police have been holding down the ground in the prone position for an extended period of time, they're already hypoxic and acidotic, and ketamine is administered, then things can go wrong. Not because the ketamine is in and of itself toxic or the wrong drug, but we're administering it to a critically ill patient. I'm also an RSI paramedic, and I use ketamine in that context frequently. And I'm well aware that when I perform an RSI procedure, I have to build in safeguards
such as pre-oxygenation, apneic oxygenation, proper positioning of the patient. And not only do I need to be aware of the risk of hypotension in a sick patient, but when I RSI a healthy, hemodynamically stable patient, they could drop their pressure. So when I'm administering those meds, I have all of those risk factors in mind. And when they occur, because they inevitably do, I'm prepared to address them. I think the same is true when we use ketamine specifically in the context that we're focused on here, which is that severely agitated patient who we're attempting to help by calming them down. I think if they're sick at that point because they're hypoxic and acidotic, as long as we've built in the safeguards that are needed and are aware of the risks, we have plan A, B, and C, then I think we're good to go. For me, the way that plays out is if we were conducting one of these together where we had concluded that someone was out of control, they were truly a risk to themselves and others, and we were going to need to sedate them to obtain control, I would look at you and say, hey, can you go back to the truck and get all the resus gear, because I doubt we're going to need it. Usually this goes well, but we might. Hey, can you go back to the truck and get all the monitoring gear? I think this is going to go smoothly, but it's critically important that we monitor this patient. I'll let you know that most patients who get ketamine do just fine. They become disassociated. They continue breathing. They don't drop their blood pressure. But it turns out every once in a while it does happen that they become apneic or that they drop their blood pressure. And we need to anticipate that that's a possibility and have a plan both for catching it via monitoring. And that's going to be your job, because I want you to make sure this patient, as soon as he can, is on all the monitoring things, and that you're paying careful attention to his pressure, to his breathing and vitals. And should it happen, I want to have the tools available to immediately address it. You're going to be there with the bag belt mask and my intubation equipment. I don't think we'll need it, but just in case.
And certainly we always want to prepare before we do anything like that. And Eric, if you're offering giving out ketamine at parties, you have our phone numbers. So, but again, I agree with you, Dan. I think when this drug kind of came out, it was, now we can do this for everything, which I think is something we, as a culture, we sort of default to that whenever there's a new thing, right? So, and this isn't just EMS, this is medicine. I mean, Dan, you've seen, and Eric, you'll know now, one of my favorite things to do when I teach is I teach when cocaine and heroin were sold by the Bayer Corporation at the end of the 19th century. Because there's advertisements where like heroin's literally called heroin because it was supposed to be a hero drug, and it got released and like this does everything, and then we realized it does do everything, and that's kind of the problem. Whereas when ketamine came out, it felt like there were two schools of thought, right? There were there's never a reason to give ketamine because in the 70s and 80s all this bad stuff happened. And then you had people referencing like Timothy Leary type of stuff. And then you had what I tend to think is more, at least my camp, which is there's almost an argument to use ketamine for more patients than there is to use them on less patients. And as we started getting into more specifics, the drug isn't vasoactive. It doesn't have all of these other problems. I think that it came more down to, we sort of taught people to give this drug and then the patient will be just fine. And that led to people not really monitoring patients. So I think that's really kind of the crux of what we want to get into. This is certainly what happened in the Elijah McClain case. It's what's happened in a lot of other cases and it seems like now, and I'm speaking anecdotally, but it seems like once a month there's a story, a patient got ketamine and they went into respiratory arrest, or a patient got ketamine and they went into cardiac arrest. And I hate to see, and I'm not trying to be like parental over the drug, but I hate seeing the chemical blamed for things that, the providers did. So when we're preparing to resuscitate, we know we need the bag valve mask, we have to get good IV access and all that. Talk to me, I guess, about the monitoring part where we've administered ketamine, we have this patient RSI'd, or we have them sedated. What are we missing that's allowing for all these deaths to fall through the cracks?
Yeah, honestly, I know a lot of people in this context have said, boy, the real problem is better to monitor after ketamine's been administered. I actually don't think that's the right focus. I think the right focus is monitoring from the outset. That is, if I'm because when I perform RSI, I don't put the monitoring equipment on after I push the paralytic, right? I want it ready to go. The one piece I can't put on immediately before is my end-tidal CO2 in the RSI context, but literally the probe is right there. So I think one of the mistakes we've made is failing to recognize that ketamine is a very effective drug. It works very quickly in these severely agitated patients. And we really need to be monitoring the patient, preferably before we give the ketamine. But in these agitated patients, obviously you can't get all of the vital signs monitoring things on, but have them there immediately ready to go. And in lieu of having the monitor on, someone, you if you're administering the drug, or one of your colleagues needs to be focused on that patient's airway and breathing. In the unlikely event that the patient, their breathing slows or stops, or their blood pressure begins to deteriorate and they become altered, we need to be able to recognize that immediately and step in. So, and so on the one hand, I fully support the concept that we haven't done an adequate job monitoring some of these patients, but I'm a little hesitant to say some of the formulations I've seen are focused on monitoring sort of after, almost so you could give the drug, toss them on the stretcher, get them in the back, and then hook them up. And actually, we've seen some examples where exactly that right approach got people in trouble because they didn't recognize how quickly the clinical situation could change.
So talk to me about that for a bit, because, and I think you're right. I think that especially with an agitated patient, and you know, a couple of years ago we talked about the John Gallagher case out in Missouri, where I guess operationally, if we have a patient who's agitated or who's generally annoyed at us, and now I'm going to jab him with a needle, people are going to ask, well, or they'll say that it's difficult to monitor someone who's being aggressive, and that's probably true. But walk me through some of, I guess, the basic assessment stuff that you can do with an agitated patient, and it's specific, like if they're yelling at you, they're breathing, right?
Yeah, no, absolutely. I think one of the things I hear frequently from paramedics is, look, Eric, if they're truly out of control, I don't have time to do all that stuff, to get all that stuff. I have to keep the patient safe. I've got to get the ketamine on board and get them calmed down. And I got to say, every single patient that I RSI, I'm RSIing them because they're in severe respiratory distress, and without placing that endotracheal tube, they're likely to die. And yet, you'll never see me rush to do an RSI. In fact, there's a big conversation going on in the community now about whether all RSIs should be de-essized, delayed sequence innovations. It's because we have a recognition that what we're doing may be life-saving, but is also a sort of a danger zone, and that regardless of the extremis of the patient, there are some things I need to do to prep in order to ensure I can do that procedure safely. I think it is exactly the same in the context of what I call pre-hospital chemical sedation. We need to think of it as a procedure. Those patients are difficult to monitor, so you can't necessarily, pulse oximeter, blood pressure cuff won't work on a patient who's thrashing around. And yet, we as providers can perform an assessment. I can have you sitting right next to that patient as I get the rest of my things ready and say, hey, pay careful attention to this guy's breathing. Right now, he's very agitated. We can see that he's breathing. He's got an adequate blood pressure for sure. He's got an adequate pulse, but that can change dramatically after we administer this drug. And so until we can get all of our monitoring gear on, you as an EMS provider, you're going to be paying close attention to that patient, which is literally, once I RSI a patient, 100% of my focus. Even though I've got all the monitoring gear on, I'm still critically focused. That's my tube. That's my airway. I paralyzed that patient, and I own the responsibility for ensuring that nothing goes awry. So 100% of my focus needs to be there. And I say that because and again, one of the things I should mention when we look at these incidents and these videos, I try really hard not to judge the providers involved, because I don't know what their protocols were. I don't know what their training was, their medical direction, their leadership.
It's already a no-win situation for everyone involved too. There, you know, anytime any EMS patient that has made the news, it's never a great story to begin with, you know.
And I really, so for me, looking at these videos is really about understanding what we can learn that can change our practice going forward. And so I look at some of these videos and I see not just a failure to have the monitoring equipment by the patient side before you begin, conduct an assessment of the patient before you begin. If you don't have the monitoring equipment before you proceed with ketamine, then probably the monitoring equipment's not there to monitor the patient immediately afterward. And then the paramedic who's administered that drug and his team need to be exclusively focused on the patient's airway and breathing and hemodynamic status throughout the procedure.
And Danny, this is something that we've talked about, but, you know, once we've followed Eric's recommendations, we have everything prepared before we go in. You know, when that patient starts to become more sedated, you have to jump in and get a good set of vitals to make sure that the patient is at least where you want them to be to start. You want to have that end-tidal nasal cannula on them if you have it. You want to get your pressures. So when Dan, I guess when would you start throwing this equipment on? So we've got this combative patient, we get ketamine on board, boom. When do we actually start the mechanical assessment, I guess?
I think as soon as I think it's safe to do so, that he's not going to throw it across the room or he's going to attack
Yeah.
somebody with it. Most of the time you can get this stuff on, you can Jedi mind trick people into putting it on or whatever. As they start to calm down, you should be having that tracing available and you should be getting a set of vitals. But there's no other substitute, even if they are a little aggressive. Putting your hands on the patient, like getting a pulse, making sure you are, having a good radial or carotid pulse, capillary refill, look at chest rate, count a respiratory rate. All of these things don't require a monitor, but you can document them in your chart. And if something goes awry, you have proof that shows, hey, I was doing this. I was taking care of this person the whole way through. I was watching them. And once we address, like we said earlier in this, once we saw a problem, we addressed it. It wasn't matter we didn't see a problem or we ignored a problem. We were taking proactive steps. That being said, even for a non-aggressive patient, I don't think any of us should be giving any kind of mood altering or consciousness altering substance without having them on a monitor and having internal CO2. I think it's just a win. I think I believe it's standard of care in the ALS world. I think it absolutely will give you the information you need to keep that patient safe. You have the ability to intervene. I can tell you it worked for me. The last time I did give somebody ketamine for pain management, they did go apnea, and I saw that happen. Right on the tracing, boom. I was like, oh, hey, get a bag mask. Let's give him a couple breaths. And he came back, and he started to breathe again. It's transient. It doesn't last forever. But with these sick people, who knows what's going to be the tipping point? So be on top of it.
And I think that's also a really good point, is that it's a period of apnea will be transient and won't last forever, provided it's actually addressed. And I think this kind of stems from a fundamental misunderstanding of ketamine too, right? Where there's anecdotal stories of patients going into a K-hole and then the providers just waiting for them to come back out of that. So Eric, talk to us a little bit about what we can expect if a patient receives a medication. What type of changes are expected? Obviously, we have to look for negative changes in apnea or bradycardia. But as I'm looking at a patient, what's the common post-medication response I should look for?
Well, I did want to comment on something you just said, which I think is incredibly important. You said they may experience apnea and it may be brief. But again, I will tell you that in, for example, a child undergoing procedural sedation in the ED, if they become apneic, first off, we have a team monitoring them constantly, as Dan just alluded to. And then we begin immediately. And even if they are apneic for 5-10 seconds, there's little clinical harm that does. If, on the other hand, you have consumed methamphetamine and you're tachycardic and hypertensive, you've struggled with the police and you're now profoundly acidotic, and you're breathing rapidly and deeply, then it turns out actually a brief period of apnea can be extremely dangerous because you're now going to tip over from barely compensating to uncompensated acidosis where you can go into cardiac arrest. So I think this is the kind of training that we fail to do with our paramedics, is to say, understand the context in which you're using the drug and the things that can go wrong with a sick patient as opposed to a otherwise healthy individual getting ketamine for sedation.
And another good point you're making is, these agitated patients, I don't think we regard them as sick. I think a lot of paramedics just look at them as, well, they're agitated. There's a mental thing. There's a psychological thing. They're
inconvenient. They're regarded as inconvenient. We give them ketamine to put them asleep for our convenience.
Could be an inconvenience. But we have to start, I think that's a good paradigm switch. We have to start looking at these people as, hey, you know what? They're potentially really sick. They have acid-base derangements. They have electrolyte issues. They are metabolically prone to collapse. And we need to be aware of that, and we need to be ready for that. And I think if we're not, we're putting ourselves behind the 8 ball. We're putting ourselves in a real jackpot if we don't recognize that, and that's just simple science.
Yep, I think that's absolutely right. And I think as the science around these deaths in custody continues to evolve. We're trying to get a better understanding of the pathophysiology. I think, unfortunately, something else that made life difficult for paramedics was some of the flawed concepts that we had built into the system, like excited delirium. I think distorts our understanding of what's going on with these patients.
Absolutely.
And in the background, I mean, I've had conversations with a variety of folks about, gee, do we think these deaths are more about hypoxia, more about acidosis? But the recognition is if you've used methamphetamine and wrestled with the police, you're likely to be acidotic. If you've been held in a prone position for an extended period of time with weight on your back and you're semi-conscious, very clearly, clinically, that patient is sick. They're probably both hypoxic and acidotic, and it wouldn't take
Right.
much to push them over the edge.
No, and that's exactly true. And that's another one of the problems with keeping someone in a prone position is your chest is designed to expand outward. And when you're held prone with pressure against you, it's difficult to actually get chest expansion on top of the other acidoses that they might experience. And it's just bad overall. So one last thing, Eric, before we get out of here, if we're in a position where, you know, we're told to give ketamine, ketamine's a drug to give, and there's some sort of competition, or you have a very conservative medical director who removes ketamine from the truck. Give me a reasonable alternative that's, you know, is it if in an excited delirium with air quotes, is that a benzodiazepine? Are we, you know, leaning more toward other medications? Are you an etomidate guy? If in a world we Thanos snap all ketamine off the planet, what's your preferred alternative?
Well, there are certainly systems that are not using ketamine today for whatever reason. I think either droperidol alone or droperidol plus midazolam. We see both of those used. Those both show up in the ASAP recommendations in this area. A lot of systems have introduced droperidol as almost an intermediate solution between like a Haldol and midazolam alone or together at a low end. Ketamine, and I think this is an important point, ketamine I think of is really for that severely agitated patient who is an active threat to themselves or others. And I know we were joking around a little bit, but I think it's very important that paramedics understand that the reason we're sedating these patients is never for the convenience of the police or never for our convenience. No, and I know you meant it this way, but I just wanted to provide that clarity that it's always because the patient is either an active threat to themselves or others. And interestingly, in both the training and protocols, I'm seeing people, I advise other places on construction of their protocols. I think it's important that we make truly clear to paramedics that ketamine is for that severely agitated patient where when you administer the drug, because a lot of these videos we see paramedics show up on scene, there's been a wrestling match with the police are telling the EMS providers how agitated the patient was. But I'm watching the video, and right now they're sitting on the pavement perfectly still and not terribly agitated at all, and yet the paramedic proceeds to administer ketamine. And I actually think the right answer is in that context, you no longer have an indication for immediate administration of ketamine. I will also say, I think part of that assessment, because you mentioned the excited delirium, part of the assessment when we show up needs to be, yes, of course, we take reports from our law enforcement colleagues. Yes, of course, we assume they're likely giving us the correct and an accurate story. And your obligation as an EMS provider, or in particular as a paramedic who's considering the administration of a powerful drug like ketamine, you have an obligation to conduct your own assessment, to take the time to determine, was this individual agitated before they encountered the police, or the agitation only, and therefore suffering some kind of psychiatric emergency or some kind of substance use disorder emergency, or was this somebody who was just walking down the street having bought Twinkies at the convenience store, but through an unfortunate encounter with the police, they become agitated, but the agitation, after you begin to assess it, is mostly about the fact that they can't breathe effectively while being held on the ground.
Yes.
One more thing I want to leave you guys with is I do think if you're going to administer ketamine or any sedative, some of the things you need to think about before you proceed in every single case, even where the patient's truly out of control, is I'm not going to ever administer that sedative to a patient in a prone position. I think that is something that we know to be inherently dangerous. And more generally, you always need to assess as to whether your patient is in a position where they can breathe adequately and get an adequate ventilation and tidal volume. Because administering any sedative in the context where your patient can't breathe adequately and adequately oxygenate and ventilate, you're asking for trouble.
And just one more thing on that, document that you made these positive changes. You know, in the narrative or in your PCR, it should absolutely say when you were out down seeing that patient was prone, you advised law enforcement to turn him over so that he was supine. We sat him up, we assessed his airway. We were able to talk to him. He was not able. Then we get into what he was like so that we gave the medication. One of the ED docs I really look up to, a guy I like a lot, is Ruben Strayer, and he's done a lot of stuff on ketamine. One of the things that he says is his decision point for giving ketamine to the agitation patient is dangerous and disruptive. If you're not dangerous and disruptive, we shouldn't be doing. There's other things we can be doing. Simply disruptive, simply being a pain in the you know what. We got other ways to deal with that.
Right. There's a difference between annoying and disruptive.
We don't need to take this step. But
I think that's
then we have to.
I think that's absolutely right. And in some of the videos we've seen, it's unclear that the patients actually meet the appropriate indication for ketamine. I think the other piece of that for me when I train with folks is to make it clear that you should pick the agent you're going to use based on the level of agitation. And you're referring to Dr. Strayer as that sort of 3-tier setup where he advocates the same thing, using, for example, grandma's agitated and demented, and you just need to give her something to calm her down a little bit. It's a very low dose benzo, or actually maybe one of the things we have seen, talking about ketamine being used for everything, pain dose ketamine at a very low dose to just calm grandma down a little bit so that we can properly assess and treat her. If you have a more agitated patient, stepping it up to a combination of a Haldol and a midazolam, or perhaps a droperidol. And then ketamine, at least in my view, is for those truly agitated patients that, as we said, are a danger to themselves and others.
And that's the most important thing is the patient being dangerous to them or to the ambulance crew or to the police or bystanders. I think that's the most important thing. And, there was a lot of conflict over excited delirium being an actual diagnosis years ago. But I think this is an important topic to talk about. Like I said, we tend to be pro ketamine. But I know the conversation is going to keep on going. Thank you so much, guys, for watching. Be sure to like and subscribe down below. Eric Jaeger from True North, thank you so much for joining us today. Any questions or comments you guys have about ketamine, let us know. We'll see you guys next time.